My name is Matthew Goldberg. I'm a dermatologist and dermatopathologist and medical director at Castle Biosciences. And in the session today, we'll be covering the comprehensive diagnostic offering from Castle Biosciences, a highly accurate and objective test to help add clarity to the diagnosis of difficult to diagnose melanocytic skin lesions. To start, we'll focus on the issue of ambiguity and discordance in the diagnosis of melanocytic neoplasms. And difficult to diagnose melanocytic lesions are actually a significant problem for dermatologists and dermatopathologists. And it's estimated that of the 2 million biopsies per year that are evaluated by dermatopathologists, there are over 130,000 malignant melanomas that are diagnosed and almost 100,000 melanoma in situ that are diagnosed. But what's often lost in those statistics is that there are 300,000 lesions that are equivocal or not able to be confidently signed out by dermatopathologists, and this leads to significant ambiguity in the treatment plans for the patients who receive these equivocal diagnoses. And the impact as well of this ambiguity is quite significant. And that's because that when you have a diagnosis that is equivocal, it's unclear which treatment plan your patient should pursue. And the allocation of healthcare resources that follow with an uncertain treatment plan can be significant, as well as the impact to the patient. And significantly, it can lead to potential for overdiagnosis or an overtreatment and underdiagnosis and potentially undertreatment of malignant melanoma. In addition, without confidence in diagnoses, it can affect and impact relationships between dermatologists and their dermatopathologists, which can have consequences down the road as well. This slide really highlights the workflow for how these melanocytic lesions come into dermatopathology and how they're handled today. So of the 2 million biopsies that come in for evaluation, the vast majority of these, we estimate 74%, are actually of benign nevi. And here seen on the top line here in blue, these benign nevi can be confidently assessed by dermatopathologists as benign nevi, and they can return to their dermatologists as not requiring any additional treatment. They can return to routine follow-up. Here in the bottom row, dermatopathologists can confidently diagnose melanoma in situ and invasive malignant melanomas, with the 11% that actually represent malignancies. And these will be treated with wide local excision or definitive surgical treatment. And depending on the type of a lesion that they're dealing with and the specific features such as Breslow depth, ulceration, as well as features like the gene expression profile of the malignant melanoma, different management decisions and management approaches can be taken, such as pursuit of sentinel lymph node biopsy, as well as follow-up intervals that are selected based on the risk of recurrence and metastasis, as well as follow-up imaging and increased surveillance. Here again for the talk today, we'll be focusing on this zone here in the middle, the orange section here of lesions with uncertain malignant potential, because these are cases where the diagnosis remains uncertain even after evaluation by dermatopathology, and where the diagnosis could span both benign and malignant entities in the differential diagnosis. In current practice, what happens is that lesions are actually treated to the worst case scenario in the differential diagnosis, but these lesions may not actually require definitive treatment because the diagnosis is fundamentally equivocal or uncertain. And so the unmet clinical need here for gene expression profile testing is that we can use additional information to help disambiguate lesions that fall in this orange category and more accurately identify them as being either benign or malignant lesions so they can pursue appropriate management plans that are aligned to the biology of the tumor itself. This diagnostic ambiguity can lead to clinical management uncertainty and complex conversations with patients regarding their treatment and follow-up. This has been well documented in the literature with ranges of ambiguous lesions from 17% to 30% in the published literature. And so this is a non-trivial set of cases that receive these equivocal diagnoses. And the impact of this ambiguity is also significant because when there's discordance in how dermatopathologists interpret these cases, the frequency of this occurrence is actually quite high, ranged to be 25 to 43% of lesions that are actually difficult to accurately characterize, but also that the things that are actually discordant, pathologist to pathologist, range not only from the specific diagnosis, but also some of the key factors that underpin the diagnosis and characterization of malignant melanomas, such as Breslow thickness, ulceration, mitotic rate. And when there's changes in these factors, one pathologist to the next, as is often the case when a second opinion consultation takes place, you can actually have changes in the staging criteria that risk stratify by clinical pathologic features alone by AJCC. And this 20% change in AJCC staging represents significant discordance that impacts potential risk stratification for patients and actually speaks to the subjectivity that's at stake in dermatopathology review of cases and where there could be benefit from having an objective and accurate measure of risk that's based on the tumor biology. So that brings us to gene expression profile testing for the classification of difficult to diagnose melanocytic neoplasms. And this is a workflow for essentially how biopsy tissue moves through the dermatopathology office. First, we start with a slide, a microscopic evaluation of the lesion with an H&E slide. And quite quickly, dermatopathologists can actually identify which lesions are benign, which lesions are malignant, and which lesions require additional workup, which is seen here in this orange box of uncertainty. And again, this is a rapid assessment that you can see really quickly when you have experience of looking at melanocytic lesions under the microscope. And dermatopathologists have a really strong handle on how to approach these difficult cases, where they can get deeper levels into the block, they can use immunohistochemical stains routinely, they can bring the slide over to a colleague across the hall, or maybe bring the case to a consensus conference that they have at regular intervals on their dermpath office. And through these approaches, dermatopathologists can get to a certain diagnosis, get to a confident diagnosis, very frequently seen here in the second column here with benign and malignant lesions. But even after this workup has been completed, the diagnostic steps that dermatopathologists have access to have been done, there remain additional lesions where the diagnosis remains uncertain, where there's significant ambiguity in whether the lesion represents a benign or malignant melanocytic neoplasm, and we have additional tools, ancillary tests for this zone. And seen here, the list of options that dermatopathologists have include second opinion, array CGH, FISH testing, as well as gene expression profile testing, or GEP, to help identify whether the lesion is a benign or malignant lesion and really help aid in the classification based on the tumor itself. The NCCN guidelines have actually described the types of modalities that can be used to help dermatopathologists get to clarity. How do you get to diagnostic certainty? And you can use a range of these different modalities. And listed here are the things that we just discussed, specifically immunohistochemistry, FISH, CGH, and also gene expression profile testing, among others, as methods that dermatopathologists can employ to go from uncertainty to certainty and add clarity to the diagnosis of these challenging melanocytic neoplasms. So again, we look at the range of ancillary test options that are available for dermatopathologists, and for the next portion of the talk, focusing here at the gene expression profile options that are comprised within the comprehensive diagnostic offering from Castle Biosciences with the MyPath melanoma assay and the DecisionDx DiffDx melanoma assay that are both gene expression profile tests designed to address this unmet clinical need to help disambiguate lesions with uncertain malignant potential. That brings us to the Castle Biosciences comprehensive diagnostic offering. And what will happen when a lesion that's submitted for testing arrives at the Castle laboratory is that first the MyPath melanoma test will be run. And after this test has been performed, a result will be given of benign, intermediate, or malignant gene expression profile score. And one of the issues with the MyPath melanoma test in prior iterations and use of this test in clinical practice is that there was a high rate of intermediate test results. And to improve the rate of actionable results that are returned from the comprehensive diagnostic offering, cases that receive an intermediate result will be subsequently tested with the DecisionDx DiffDx melanoma assay, again to use gene expression profile testing to determine whether the gene expression represents that of a benign, intermediate, or malignant melanocytic neoplasm. And so through this approach, with these two gene expression profile tests in series, first MyPath melanoma and then the DecisionDx DiffDx melanoma, we're bringing two gene expression profile tests to the care of patients with difficult to diagnose melanocytic neoplasms to go from uncertainty to certainty, to add clarity to the diagnosis and characterization of these lesions. So first on the MyPath melanoma test. MyPath melanoma is a gene expression profile test that is based on the quantification of gene expression of 23 genes from primary melanocytic lesions using RT-PCR approach to quantify this gene expression. Importantly, there are two hits on the PRAME gene itself, which is a marker that has really grown in importance here in the characterization of melanocytic lesions in past years. And effectively, this gene expression profile is designed to classify lesions objectively and accurately as benign, intermediate, or malignant. And the report score that you receive for lesions that are tested with this assay is not just benign, intermediate, and malignant, but it actually contains the full text that's seen here. So the gene expression profile that's suggestive of a benign neoplasm, a gene expression profile where a malignancy can't be excluded for intermediate lesions, and on the malignant side, a gene expression profile suggestive of a malignant neoplasm. There are 9 publications that support the clinical validity of the MyPath melanoma test for ambiguous melanocytic neoplasms, and over the course of study, there is robust evidence that this test can accurately and reliably classify lesions as benign or malignant using this gene expression profile assay as a diagnostic adjunct to histopathology review of these cases. The MyPath melanoma test is validated against multiple reference standards, and the accuracy of the assay has been evaluated using two types of ground truth. The first is diagnosis of experts, or as we commonly refer to it, consensus diagnosis by dermatopathology review. And what this means is that the test had a very high sensitivity and specificity, 90% sensitivity and 91% specificity seen here on the left, where the test was accurately able to identify lesions that a group of dermatopathologists termed benign or benign nevi as benign by gene expression profile testing, and a group of malignant melanomas considered to be malignant melanomas by a group of expert as having a malignant gene expression profile score. Importantly, when compared to patient outcomes, the test continued to have a high sensitivity and specificity, specifically when compared to malignant lesions that produced melanoma metastases or benign lesions that in fact did not produce melanoma metastases. And again, the test maintained a high sensitivity and specificity seen here on the right with 94% sensitivity and 96% specificity. And so what these two different approaches demonstrate is that the MyPath melanoma is an accurate assay that can appropriately provide information to dermatopathologists to aid in the diagnosis of a lesion as being benign or a lesion as being malignant. MyPath melanoma has also been used in over 35,000 clinically tested cases that were difficult to diagnose, submitted for testing by dermatopathologists. Now, of the cases that were submitted for testing, approximately 65% were actually benign by the gene expression profile score, with 23% receiving a malignant gene expression profile score. And the 12% here received an intermediate score. And this is really in this intermediate zone where the DecisionDx DiffDx melanoma test fits in, because previously that was the end of the road. That was the end of the test for those lesions that were tested with the MyPath melanoma test. And now all lesions that receive an intermediate score that are appropriate for testing with DiffDx melanoma will subsequently be tested with this second gene expression profile assay. Now, the DiffDx melanoma test differentiates as well between benign and malignant melanocytic lesions of uncertain malignant potential. And this is a gene expression profile test based on 35 genes, again from primary melanocytic biopsy tissue, that uses RT-PCR and a neural network algorithm to produce a gene expression profile result of benign, intermediate, and malignant, again with a gene expression profile that's suggestive of a benign neoplasm, a gene expression profile where malignancy can't be excluded, and a gene expression profile where that is suggestive of a malignant neoplasm. And again, this is a test that can objectively and accurately classify lesions based on their gene expression to aid in the diagnosis of these difficult to diagnose lesions. The evidence in support of the DecisionDx DiffDx melanoma test comes from the development and validation study that was published in late 2020. And in this study, there was a very high sensitivity and specificity of the assay, with 99.1% sensitivity and 94.3% specificity, with only 3.6% of cases receiving an intermediate result. And this really speaks to the very high rate of actionable results that are received from those lesions that are submitted for testing from the DecisionDx DiffDx melanoma. And what's more, the development effort included a range of melanocytic nevi subtypes and a range of malignant melanoma subtypes that included very commonly encountered diagnoses, such as compound nevi and intradermal nevi, and on the malignant side, superficial spreading melanoma and nodular melanoma, as well as less commonly encountered subtypes, such as nevoid melanoma and desmoplastic melanoma. Importantly, both the benign nevi and the malignant melanoma included junctional melanocytic lesions, specifically junctional nevi, junctional dysplastic nevi, and melanoma in situ. The demonstrated clinical utility for the MyPath melanoma assay and the DecisionDx DiffDx melanoma assay has been demonstrated for both dermatopathologists and dermatologists, and the clinical utility is slightly different for these two different types of providers. For the dermatopathologist, the receipt of the gene expression profile information impacts their sign-out and their diagnostic report in 50% of the cases that are submitted for testing. And what's more, in a study of DiffDx, the diagnostic confidence that the dermatopathologist had when rendering their diagnosis increased in 51% of the cases for which they received a result. On the receiving end of the report for the dermatologists, there was an 80% reduction in re-excisions for lesions that received a benign result with a MyPath melanoma test, suggesting the utility of the test to decrease unnecessary re-excisions in benign melanocytic neoplasms whose tumor biology did not necessitate re-excision following initial diagnosis. In summary, the comprehensive diagnostic offering leverages the strength of both the MyPath melanoma assay and the DiffDx melanoma assay by positioning these two gene expression profile tests that are designed to address the same unmet clinical need of difficult to diagnose melanocytic neoplasms. By positioning these two tests in series, first lesions are tested with the MyPath melanoma assay, which has the strength of 35,000 clinically tested cases and 9 publications that characterize over 2,000 melanocytic neoplasms. And in these studies, there's a reported sensitivity of 94% and a specificity of 96% when you compare the performance of the test to lesions that produced melanoma metastases or not, when you compare the test to clinical outcomes. And in lesions that received a benign result by gene expression profile testing, it resulted in an 80% reduction in re-excisions, suggesting a clear clinical utility for how clinicians can take up the gene expression profile test, change management, and improve patient health outcomes. For those lesions that receive an intermediate score from the MyPath melanoma test, they can now be tested with the DecisionDx-DiffDx melanoma test to provide additional diagnostic clarity and aid in the diagnosis of these difficult to characterize melanocytic lesions. Now, this test was developed using neural network algorithms for the model development and tested on a wide variety of melanocytic lesion subtypes, and it benefits from having a low rate of intermediate results, so that the vast majority of lesions that are sent for testing with the DiffDx melanoma assay will receive a clinically actionable result, which can be integrated into the report and diagnosis of the melanocytic lesion sent for testing in the context of the clinical features, the laboratory features, and the histopathologic context to provide an improved diagnosis that's informed by an objective and accurate gene expression profile comprehensive diagnostic offering. The clinical utility of the comprehensive diagnostic offering has been shown to be slightly different for dermatologists and dermatopathologists. And for dermatopathologists, it can lead to more actionable pathology reports where the pathologist can have more confidence in their diagnosis that's fueled by an objective and accurate measure of the gene expression profile of the lesion that's submitted for testing. And it can help inform the type of guidance that dermatopathologists give to their colleagues in dermatology when they submit a report as final. On the receiving side, for the dermatologists, it can help make your pathology report be more clinically actionable. So instead of having an equivocal diagnosis that may span a benign and malignant type of melanocytic lesion, you can gain diagnostic clarity and identify whether a lesion actually requires additional definitive surgical therapy or can return to clinical monitoring, informed by the synthesis of the gene expression profile test in the context of the clinical, laboratory, and histopathologic features of the lesion submitted for testing, and really inform appropriate management plans for these challenging cases that are submitted for testing. It can also increase the confidence that the treatment plan that you set forward with your patient is the right one, informed by the biology of the lesion itself. And finally, there can be rapid access to the DecisionDx melanoma test itself to provide important prognostic information when that will inform management decisions for your patients with melanoma. The tissue requirements for submitting a test to the comprehensive diagnostic offering are the same as they are for the other dermatology assays that Castle Biosciences offers, specifically 1 H&E slide and 9 unstained sections. Alternatively, a block can be submitted from the tissue, and Castle Biosciences will prepare the slides appropriately for testing. Fundamentally, prior to testing, the clinician must certify that the malignant potential of the lesion is uncertain. And what that means is that this test is being applied to cases where there is clear clinical utility and where the gene expression profile test result can impact patient management by providing more diagnostic clarity to the clinician that's submitting the lesion for testing. There are some limitations on the types of lesions that are appropriate for testing, and fundamentally the test is suited for formalin-fixed, paraffin-embedded tissue that is from primary cutaneous melanocytic lesions. The DiffDx melanoma test is only appropriate for patients over the age of 18, for adult patients, whereas the MyPath melanoma test can be used in patients of all ages. The gene expression profile signature for both tests has also not been validated in metastatic melanomas, non-melanocytic skin lesions, and lesions that have been subjected to prior treatment such as radiation therapy, and those samples remain unsuitable for testing. And finally, the tumor content of the lesions that are submitted for evaluation must have 10% tumor content identified in order for there to be enough melanocytic tissue to really perform the gene expression profile test and ensure that the result is appropriate for the lesion that are submitted for testing. Finally, I'd like to conclude with one of the main advantages of the comprehensive diagnostic offering. Now that both the MyPath melanoma test and the DecisionDx-DiffDx melanoma test are integrated into this new workflow, both of these tests can be applied to your patients with difficult to diagnose melanocytic lesions to move from uncertainty to certainty, to take lesions that have an equivocal diagnosis or an uncertain malignant potential, and use the gene expression profile of these lesions to inform the diagnosis in the context of the clinical, laboratory, and histopathologic information to provide an objective and accurate assessment of the lesion and characterize it as a benign lesion or a malignant lesion, or one with intermediate malignant potential. And once this is complete, those lesions that are diagnosed as malignant melanoma, whose diagnoses change after the gene expression profile test has been integrated into the final diagnosis, those cases can subsequently receive the DecisionDx melanoma assay if it is appropriate for testing and informs management decisions for patients with confirmed invasive malignant melanoma. And those management decisions range from decisions for sentinel lymph node biopsy, as well as risk stratification based on risk of recurrence and metastasis. And so by bringing these tests together, we can add clarity to the diagnosis of these difficult to diagnose melanocytic lesions and have tissue-sparing access, rapid access to the DecisionDx melanoma test for patients whose management will be benefited by this additional prognostic information after the diagnostic uncertainty has been addressed. With that, I thank you for your time and attention here. And if you have additional questions and are looking for more information about the comprehensive diagnostic offering or other gene expression profile tests for your patients with dermatologic malignancies, please reach out to your Castle representatives, or also please contact me here at my email on the screen, and be happy to discuss further with you at any point.